Hi everyone, I'm Dr. Manuel Reyes, a practicing glaucoma specialist here in Manila, the capital city of the Philippines. I'm here in connection with being a volunteer of the faculty of the Orbis International. I will be joined later by two most sought after glaucoma specialists, Dr. in my right, Dr. Romel Bautista, who finished his fellowship in Stanford University. And on my left is Dr. Rainer Kobar, who finished his fellowship in the University of Sydney, Australia. So I was asked to lecture or say something about minimally invasive glaucoma surgery. These are my financial disclosures. So these are the pre-lecture questions. Number one, Slem's canal MIGS is usually indicated for advanced glaucoma patients, close angle glaucoma, mild to moderate primary open glaucoma, and or letter D, refractory glaucoma. Please answer now. Oh, okay. So everybody got that correct. Number two question. CyPass was taken out of the market primarily because of letter A, IOP was not lowered as claimed. Letter B, difficulty of the technique. Letter C, endothelial cell loss. And letter D, too many early post-operative complications. You can answer now. Okay, the right answer for that question is endothelial cell loss. Question number three. The following MIGS challenges the Slem's canal, except number A, letter A, in focus. Letter B, eye stent. Letter C, hydrus. And letter D, trabeculectomy. You can answer now. And the right answer for that question is except in focus. Question number four. Moderate to severe glaucoma can benefit from letter A, eye stent. Letter B, hydrus. Letter C, Cahook dual blade. And letter D, sand gel implant. Yes, majority got it, sand gel implant. Okay, since we will be discussing MIGS, we will focus on the primary open angle glaucoma. As we all know, primary open angle glaucoma comprises 74% of the total global glaucoma cases, and by now, it has reached about over 50 million patients. Topical anti-glaucoma medications has been our first line. However, because of the rising problem with regards to adherence, compliance, persistence of putting the drops, and on top of that, here in the third world, the expensive cost of the medication, progression of the disease is inevitable. Selective laser trabeculoplasty is another good first line to some patients, especially in mild to moderate cases. However, not all respond to it, and if they do, they lose its effectiveness over time. In the recent years, new devices for microinvasive glaucoma surgery were developed and have gained more interest among glaucoma specialists as well as general ophthalmologists. According to Saheb and Ahmed, the term MIGS refers to a group of surgical procedures which share 5 preferable qualities: an ab-interno approach to a clear corneal incision, which is conjunctival sparing, a minimally traumatic procedure to the target tissue, an IOP lowering efficacy that justifies the approach, a highly profile and a high safety profile which avoids serious complications as compared to other glaucoma surgeries, and rapid recovery with minimal impact to the patient's quality of life. The course of our discussions will deal with these issues as well, with all these issues. So MIGS sort of fills the gap between the conservative and the surgical management. Previously, if we cannot stabilize our patient with 1, 2, 3, or 4 medication and plus SLT. Sometimes we begin to think of trabeculectomy, but now MIGS can be done to avoid serious complications that our beloved trabs are very well known. So before we start our discussion proper, I would like to mention that most of the studies that will be presented are industry-involved investigations. However, this does not negate the encouraging findings of the results that is worth mentioning. MIGS are classified according to their mechanisms. So, mechanisms in which IOP is lowered by MIGS includes the Schlemm canal's MIGS. It increases trabecular outflow by passing the trabecular meshwork. The iStent and Hydrus are stent MIGS. Trabectome and the Cahoot dual blade are ablative or unroofing MIGS. Suprachoroidal MIGS increases the uvuscular outflow, and CyPass and iStents are its model. And lastly, the bleb-forming MIGS creates a subconjunctival drainage pathway like the SEN 45 gel shunt and the InFocus micro shunt. This will be the scope of our topic for tonight's webinar: the Schlemm canal surgeries and the bleb-forming surgeries. MIGS devices are small and even very tiny. These are their actual sizes. There are numerous YouTube videos on how to put it. You can check it and learn from it. It will not be included in this webinar. So first we discuss about iStent MIGS. It is the first MIGS approved in last 2012 in the US. It was approved as combination procedure with phacoemulsification, and in Europe, it can be used as a standalone or combined with phaco. As was claimed, it is indeed indicated only for mild to moderate glaucoma and not used for severe stage of the disease. Currently, we could say that this is the gold standard amongst the MIGS devices because of its well-established efficacy and safety. This is also the most widely studied MIGS. Its mechanism is to create a permanent opening into the Schlemm canal. The recent meta-analysis involving 1,767 eyes from 28 different studies, and among these subjects, they implanted only 1 stent in 999 patients, 2 stents in 685 patients, and 3 stents in 63 eyes. IOP reduction using the first first generation stent, the mean IOP reduction of doing iStent implantation is around 4.67 millimeters mercury if one device is implanted, 6.03 millimeters mercury if 2 devices are implanted, and 9.33 millimeters if 3 devices are implanted. This only tells us that 3 stents is better than 2, 2 stents is better than 1. Data revealed that the iStent alone group produces a significantly more pronounced reduction in IOP than the phaco iStent cohort. The iStent alone group also had significantly greater preoperative IOP than the phaco iStent cohort. Nonetheless, the iStent alone cohort had lower postoperative IOP relative to the phaco iStent cohort. There was a significantly greater IOP reduction in the phaco plus in the phaco plus iStent group when it was compared to phaco alone. Now we talk about the iStent Inject. This is brought about by the previous study that 2 stents are better than 1. In every injector, there are 2 stents that is stuck in 2 different sites. This probably resulted in the previous study that 2 stents are, just like what I said, better than just one. In this study, phaco iStent IOP reduction was 8.52 and pre-op of which are 23.39 and post-op IOP was 14.94. iStent only group IOP reduction was 9.99 with a pre-op IOP of 24.18 and after 12 months of study, post-op IOP was 14.13. There was also a greater number of medication decrease with the iStent alone group. In the analysis of using a second-generation iStent Inject, iStent alone had a significantly greater IOP reduction as compared to the phaco iStent. As to the safety profile, most common adverse effects is IOP elevation immediately post-op, which was attributed to the viscoelastic use during the procedure and eventually resolves without any complications. Other complications include stent blockage, malposition, minimal hypema. Most studies reported that they ended stable or with improved visual acuity at the last follow-up. The use of iStent Inject is as effective as 2 medications as seen in this study, wherein they have 2 populations, the iStent group and the medical therapy. However, with the iStent group, they benefit from flat diurnal curve, no drug systemic, and local side effects. iStent implantation may be viable as initial treatment option comparable to topical prostaglandin and timolol in newly diagnosed primary open-angle glaucoma. Let's go to Hydrus. So this is a crescent-shaped device inserted via preloaded handheld injector, and it dilates the SLEMS canal up to 3 clock hours bypassing the trabecular meshwork. This is the efficacy study regarding iStent. After 24 months, Hydrus phaco group achieved better IOP lowering as compared to the phaco alone group. It is also worth mentioning the Hydrus versus selective laser trabeculoplasty. And the Hydrus group significantly decreases in IOP and medication compared with the baseline values, whereas the SLT group only decreases the IOP, and still the patient was given medications. So we go now to the trabectome and the Cahook dual blade, like what I said, the ablative or unroofing MIGS. This is now your trabectome system, and it was approved by US FDA since 2004. It ablates the trabecular meshwork and inner walls of the Slem's canal to promote greater flow by utilizing high-frequency electrocautery energy. It is less invasive as an internal approach and used to increase compliance, as fewer glaucoma medications are needed after the procedure. And as claimed by the company, it selectively removes the trabecular tissue, unroofing the Slem's canal, which solves the trabecular blockage. In the first study comparing trabectome plus cataract and cataract alone group, there was a significant reduction with a combined group at 9.3 millimeters mercury versus just the cataract alone group at 5.6 millimeters mercury. In the second and third study, they used it in pseudoexploitative patients, and the effect appears to be more significant in patients with PXE. After 1 month, after 1 year at 9.7 plus or minus 9.3 millimeters mercury, the authors postulated that the mechanical effect of trabecular meshwork removal facilitates the washout of exfoliative material, thus contributing to a greater decrease in the IOP. With that in mind, it can positively use for glaucomas such as steroid-induced uveitis and or pigmentary glaucomas. Trabectome safety is that trabectome procedure did not influence. This is also another study that after doing trabectome and the patient was subjected to trabeculectomy, it did not influence the outcome of the trabeculectomy as was the second operation done. We now go to the Cahook dual blade. This blade used for alternative method for performing internal trabeculotomy. It elevates the trabecular meshwork prior to removal, enabling cleaner tissue removal and minimizing injury to the nearby tissue. There is no randomized controlled clinical trials that had been published. Eyes with higher baseline IOP experience mean IOP reduction of around 13.7 millimeters mercury at month 6, while eyes with lower baseline IOP experience mean IOP reduction of 3.8 millimeters mercury. The mean medication were reduced by 1.3 medication in the high IOP eyes and 9.9 or 1 medication in the low IOP eyes at month 6. The adverse events were non-sight-threatening and very usually self-limited. So, minimally invasive glaucoma surgeries, the Slem's canal surgeries or the Slem's canal group, the eye stent, the trabectome, the Cahook dual blade, and the Hirus. Who is it for? We can therefore say that they are for the mild to moderate primary open-angle glaucoma patients when you need target IOPs in the mid-teens to high teens, when patients have poor compliance or tolerance to topical medication, in patients with persistent high IOPs after SLT, for pseudophakics or combined with cataract surgery, and for trabeculectomy and cahook blade. It also works well with pseudo-expeditive glaucoma and pigmentary glaucoma. So we now go to the bleb-forming surgeries, the Sengel stent and the in-focus. The anterior tube and the anterior end of the tube is in the anterior chamber, and the posterior end is nicely placed in the subconjunctival space about 3 millimeters from the limbus. In the study by Shebani in 45 eyes, the mean IOP pre-op was 20.8 millimeters mercury, and after 12 months, it went down to around 13.1 millimeters mercury. The use of meds was also reduced from 2.7 to just 1 medication post-operative. In the study of Mansouri, wherein he compared standalone SEN to combined phaco-SEN, the results showed IOP of 20.7, at baseline IOP of 20.7 millimeters mercury went down to 13.9 millimeters mercury after a year. However, 37% of patients required needling intervention. SEN implant has good safety profile. It is the most common adverse effect is intraoperative hemorrhage and both intracameral and scleral exit point at both at the intracameral and the scleral exit point. We have to address post-op encapsulation of the filtration bleb. Thus, needling is an extreme necessity. And now, here is the head-to-head comparison of SEN implant with trabeculectomy. This is the largest and the only comparative trial with SEN gel implant and trabeculectomy as standalone. It is a multi-center retrospective cohort study, median follow-up of 15 to 17.8 months. And the population includes primary or secondary primary open angle glaucoma, mixed mechanism glaucomas, or primary angle closure glaucoma. So the result of the study is that the median pre-op was 24 millimeters mercury with 3 medication, and the median post-op was 30 millimeters mercury with 0 meds in both SEN gel implant and the trabeculectomy group. However, the TRAB group has more post-operative intervention with greater complication as compared with the SEN gel stent implant group. This is one interesting case that I want to share. The patient had a blunt trauma to his right eye causing lens rupture and iridodialysis from 12 o'clock to 3 o'clock. The surgeon successfully removed the lens superiorly by extracapsular method and put in an IOL. He was referred to our service because of uncontrolled IOP in the 40s with 3 medications. I chose to put a SEN implant short of putting a Seton bulb or a Seton procedure. The one that is circled is your SEN implant in the anterior chamber. And this picture was taken 6 weeks post-op, and his intraocular pressure was 8 millimeters mercury without any medication, with low rise, formed bleb, and less vascular rise. And this is a beautiful bleb as what we see. Now the in-focus. The in-focus microshunt is implanted in an ab externo fashion and with the help of mitomycin C. So complications noted are transient numerical hypotony, anterior chamber shallowing, choroidal effusion, self-resolving hypema, vitreous hemorrhage, and bleb leak, which resolves without any surgical intervention. So in the study of Becker et al., 1 year results of 3-site study of in-focus microshunt from France, Dominican Republic, and Netherlands, 91 consecutive primary open-angle glaucoma underwent standalone in-focus. 38 of them were phakic and 35 are pseudophakic eyes. 18 combined in-focus and cataract surgery. And the results are the mean pre-op IOP of 24.3 millimeters mercury with 2.4 meds decreased to around 13.3 millimeters mercury with 0.4 meds at 12 months. This time, prospective randomized FDA clinical trial comparing the safety and efficacy of the in-focus microshunt to trabeculectomy in primary open-angle glaucoma is going on in the United States. So, with bleb-forming MIGS, the Sengel instant, and the in-focus, who is it for? Then we could safely say that these bleb-forming MIGS are for moderate to severe primary open-angle glaucoma, severe refractory glaucomas, close-angle glaucomas, when your target IOP is in low teens, patients with poor compliance or tolerance to topical medications, and patients who are poor candidate for glaucoma filtering surgeries. So, best mix for your patient, the SLAMS canal-based surgery. This is our what we can say this time. And for the bleb-forming MIGS, these are the indications for such surgeries. In summary, MIGS has been generally proven to be a good treatment option, mostly for mild to moderate glaucoma patients with open angles, even for severe refractory glaucoma and close-angle glaucomas. It fills the gap that existed in the treatment algorithm for glaucoma between the conservative, the spectrum, and the traditional filtering glaucoma surgeries. It can be combined with cataract surgeries for convenience of the patient. And it even works better as standalone procedure. It minimizes patients' adherence problem to topical medications, and very importantly, MIGS increases the quality of life, less ocular toxicity, and potentially reducing lifetime costs of expensive glaucoma medications. Now, I turn you over to my colleague, Dr. Romel Bautista, to give us or tell us about the clinical experience with iStent G1 here in our country.
Thank you for inviting me, Dr. Reyes, and to Orbis, the organization, for allowing me to speak to you this evening or today to share with you our local experience with the iStent G1. Unfortunately, we do not have the iStent Inject yet here in the Philippines, so I will just be discussing with you our results with the first generation iStent. These are my financial disclosures. All right. The first slide shows basically the demographics of our patient cohort, which was followed up over the course of 12 months. Median age of 67, almost an equal amount of male and female patients. Status pre-operatively was that 62% had cataracts, 38% were pseudophakic, and about 5% had previous glaucoma surgery, particularly a failed trabeculectomy. In the group A, which we call the iStent Solo, wherein we essentially just inserted the iStent in pseudophakic patients, we had about 15 patients in this group. Preoperative IOP was about 21.33 millimeters mercury, and an average glaucoma number of glaucoma medications is about 2.2. Okay, in the second group, which we call the phaco iStent or phaco plus procedures, the preoperative IOP was approximately 17.48 in 25 patients, with an average number of 2.36 glaucoma medications for this group. And for when we combine both groups, the average IOP preoperatively was about 18.93 millimeters mercury. And again, glaucoma medications are roughly about 2.3 meds per patient. Here's a brief summary of our results. For the iStent solo, we had about a 28.4% IOP reduction and about a 50.45% medication reduction in this patient group. And to mirror what the experience has been in the other papers mentioned earlier by Dr. Reyes, for some reason, patients who had combined phaco and iStent did have an IOP reduction, but was significantly less than if we were to put an iStent solo alone. However, the medication reduction was roughly equal, about 55%. To combine the results, it's about 17.7% IOP reduction for both groups combined, and again, roughly about a 50% or 54.7% medication reduction. The factors for variance in the results, well, perhaps there is a slight learning curve as to how to put the first generation iStent. First of all, proficiency in intraoperative gonioscopy is a must. There's head tilting at approximately 30%, in which the microscope for the surgeon should also be pulled towards the surgeon's eye by about 30%, which increases the working distance, as compared to performing, say, for example, a Zen gel stent implant. Other factors are, of course, the placement. This could be less than ideal. It could be shallow or a partially occluded snorkel head. One of the things that I've personally encountered in placing these devices is that we normally have to target an area in the trabecular meshwork wherein we feel that the collector channels are most concentrated. And unfortunately, when you do that and you start puncturing the Schlemm's canal using the sharp tip of the iStent, there's excessive bleeding, in some cases. In some cases, the bleeding is not as bad, and the iStent can actually be placed rather quickly. The bleeding in this case is relatively is an ironic event, because you actually would like to see a bit of bleeding, because that pretty much confirms that you're actually in Schlemm's canal. And to prevent too much bleeding while you're performing the procedure, you need to pressurize the anterior chamber with a fair amount of viscoelastic. Unfortunately, if you put too much viscoelastic, you end up crushing the trabecular meshwork, which is essentially a sponge, making the implantation of the iStent a bit more difficult. Here's a picture of a target area wherein on the surface of the conch you can see a significant amount of blood vessels, indicating that perhaps maybe this is a clock hour or a quadrant that contains the collector channel. As you perform intraoperative gonioscopy when choosing a site prior to the insertion of the iStent, you'll see some patchy pigmentation on the trabecular meshwork line, and that pigmentation is actually a bit of blood reflux coming out from Schlemm's canal. This is the ideal place to put the iStent. So things to note. Overall, some eyes ended up with no meds entirely after stenting. And it's also equally important to note that before we conducted this short study, meds weren't actually discontinued. So in essence, there was no washout. So preoperative IOP should actually be higher. And more importantly, IOP reduction isn't the only parameter that matters. And I'll tell you why. Here's some raw data that we just added last minute. No? The patient is a 67-year-old male. For the right eye, we put an eye stent. Preoperative IOP was about 15 on a prostaglandin and alpha-GAN. Post-operatively, he had no medications with an IOP of 10. For the left eye, pretty much the same, 15, 16 on a PG and brimonidine. And his post-operative result was 11 millimeters mercury, again without medication. So that's a big win. You know, not only was the pressure reduced significantly, but the number of medications were also completely eliminated in this patient. Here is an 83. The first patient is an 83-year-old female who underwent phaco eye stent on the right eye. Preoperative IOP was about 16 on essentially 4 medications: PG, COSOPT, and alpha-GAN. Post-operatively, after the phaco eye stent, her pressures were 15. So from 16 to 15, it's just 1 millimeter difference. However, I consider this still a win because she's 15 without any medications whatsoever. Again, pretty much the same picture for the last patient here, a 79-year-old female, wherein we performed, or I performed, an eye stent solo with a preoperative IOP of 15 on a PG and an alpha-GAN. Post-operatively, pressures are the same at 15, but this time patient had no meds. So I guess this underlies the idea that it's not just a matter of reducing IOP for these patients, but essentially removing the burden of medication on these patients and the attendant complications that come along with it. Thank you. Thank you. Now I'm going to turn you over to Dr. Kovar to speak about the Sen-Gel 45.
Hello, good evening, or good morning, or good afternoon to some viewers in other parts of the world. Thank you to Orbis and to Dr. Reyes for inviting me over for this very short talk. So we've only had the Zen in the Philippines since January. So we've just begun, and most of the cases that we'll present today are continuous cases that we've started with, especially with the initial learning curve that we all had to go through with this. As Dr. Reyes has mentioned earlier, there are 3 types of ab interno MIGS. The Zen is part of the subconjunctival MIGS group of drainage devices. It bypasses the trabecular and scleral resistance. And the advantages being that there's no need for incisions in the conjunctiva or scleral flap, meaning you can do trabeculectomy or other procedures in the future. It creates a new outflow channel and optional pressure reduction owing to low and diffuse outflow. So the mechanism and design of the Zen was based on calculations of aqueous flow. It's because of a longer and thinner tube, it provides a larger pressure differential or more resistance to flow. Initially, there were 3 types that was developed: the Zen 140, Zen 140, the Zen 63, and presently what was produced now is the Zen 45. It's a 6 millimeter size and length with a lumen of 45 microns. These are the actual patients, consecutive patients that have done so far. We've done 12, but my data presently that we have collated is only up to around 9. 2 were females, and everyone were male. All except 2 were diagnosed with primary open-angle glaucoma. 1 had angular recession, and 1 had mixed mechanism glaucoma. These are the pre-op and post-operative IOPs. It's better presented in this graph. You will see that pre-operatively, they had the mean IOP of around 25.66. And on day 1, it has gone down to around 14.44. Eventually, it goes up a bit in the first month and plateaus down after the third month. The first day post-op seems to be a little high compared to literature values, but that is actually because if you look at the individual IOPs of the patients, there's actually one patient wherein the IOP day 1 post-op actually surged higher than it was preoperatively. It was actually because there was a occlusion in the tip of the tube inside the anterior chamber, wherein we had to do an argon or a 532 laser at the iris where the obstruction was, just so that the tip would be free of any iris incarcerating into the lumen. If we look at the data without that patient, removing that particular patient, the day 1 post-op, actually the IOP would go down to around 9, the mean IOP of all the other patients, and then still it would go up after the first week and up to the first month, but it subsequently goes down by the third month. It actually, there's actually an Allergan APEX study, which is ongoing prospective non-randomized clinical trial in 23 sites in 9 countries. And then they actually have a 2-year data already. Based on the results, it shows that their pre-op IOP of around 20 goes down to a day 1 post-op IOP of around 9 and eventually creeps up but plateaus to around 13 to 14.6 by the 9th month. That if you look at the very small sample size that we have, my local data actually mirrors that of a much bigger sample size of 215. It's a far stretch, but at least it's very similar to what their graph looks like. So the efficacy of Zen in a very small population, significant reduction in mean IOP, ranging from a 20 to 60% at all time points. If you look at the number of anti-glaucoma medications, you will see that patients preoperatively had drops of around 2 and then decreases to around 1.57 by the third month. But we have to note that it is suggested by Allergan that we decrease medications or the inflammatory anti-glaucoma medications prior to surgery and give some prednisolone topical drops to improve the post-operative results. Hence, the pre-op anti-glaucoma medications has gone down to just around 2 or so. So there's still a reduction in mean number of anti-glaucoma meds from pre-op to post-op. And lastly, if you look again at the graph, the results from this small group of patients, you will see that at the first month, there seems to be an increase in IOP. A lot of the studies, and even in trabeculectomy, we do give some 5FU during the 3rd to 4th week post-operatively. And I have done that in this small group of population as well. By the 3rd or 4th week, we gave some 5FU injection, and the mean IOP before needling of around 17.6 millimeter mercury has gone down to around 13.6 millimeter mercury after the needling. Hence, there is a lowering of the IOP by the third month. So in this paper, where there's a 6-month outcome of patients who've undergone Zen gel stent implantation and 5FU needling, we were able to show that needling revision following Zen gel stent implantation showed a good IOP lowering effect without significant increase in number of anti-glaucoma medications, decrease in visual acuity, nor any major complications. Adverse effects, one very important is the tube obstruction, although it's very common that you may get a flick during the first few times that you inject the Zen. But usually if you are able to control, especially your dominant hand, you might get away with not having a lot of hemorrhage during this procedure. So the aims of the MIGS, according to EGS guidelines with the Zen in context, is that you spare the conjunctiva, prevent significant external scarring, there's no symptomatic hypotony or major complications, and at 1 year, mean IOP may reach around 14 millimeters mercury. So thank you for your time, and thank you for your invitation.
So the first question is that what contraindication of MIGS, what features for patients who will pass MRI? So I don't think the SAN and the in-focus implants will have a problem with MRI.
The iStent is in particular, the iStent is a heparin-coated titanium stent. It's the smallest implant device in the world for any specialty. And although it is made of titanium, it is non-magnetic and rated to about 3 Tesla. So that is actually safe. It's actually safe for MRI.
The next question is the Express shunt considered a tube or a MIGS? Well, in my own opinion, going to the history of Express shunt, wherein they thought that Express shunt will have a will serve as a what do you call it? You just put the Express shunt and totally the pressure or the aqueous humor will go, you will pass through it. And then on the later part of the study, since they leave it, they tried to put it as a inside the scarf flap. So it cannot be considered as a MIGS. The next question is there a need for antimetabolites with bleb-forming MIGS? That's very true. No? The iStent and the in-focus are and the SEN. I'm sorry, the SEN and the in-focus is designed will be more worth it, or the success rate will increase with antimetabolites. In fact, with SEN implant, most surgeons nowadays, although it is off-label introduction of your mitomycin, they inject the mitomycin this time. And with what Dr. Rainier Kobar told us about increasing the efficacy of the SEN implants by needling with 5FU. So the need of antimetabolite is a necessity for bleb-forming MIGS. If you have a good deep sclerectomy surgeon, why go to MIGS? All right. Can you answer about that question? I don't perform this kind of surgery. I cannot comment on this.
Like any glaucoma procedure, I think we've all gone to a lot of other procedures in the past, but I think whatever works in your hands in managing your patients, if you can do well with the trabeculectomy, then that's fine. If in your area it might not the other MIGS might not be available, or it might be very difficult to provide for your patients, then using nylon tenno sutures for your trabs might just be fine. But MIGS, I think MIGS is there just so that you have an option for some of our patients who might not want to have a large incision, who might want to have a lot less hemorrhaging, or might want to have faster visual recovery with less amount of surgery. So I think in the end, we work with what's best in our hands and with what's good for our patients.
The next question, is there benefit of injecting MIGS at a later date after cataract surgery due to inflammation, settling down, and can MIGS efficacy decreases due to blockage, etc. by inflammatory cells? Well, a lot of the studies had shown that standalone MIGS works better than as combined with cataract surgery. So we can do that, cataract surgery. Then if you still have, and if you will still want some IOP lowering effect, and you don't want to put your patients on medication, then you can do MIGS at a later date. So can MIGS efficacy decrease? The next question is there a difference in preferred quadrant for implantation of various implants?
To answer this question, yes, there are certainly preferred quadrants for an implantation of various implants. If we talk about implanting an in-focus or perhaps maybe a SEN 45 gel implant, you'd want to put the implant away from an area that you might end up having to do a trabeculectomy later on should the MIGS device fail. So that's you want to take up as little real estate as possible as far as the conjunctiva is concerned. And as again, if you are putting a SEN or an iStent into trabecular meshwork, then the preferred site is the site that shows the patch patchy pigmentation, which typically is the site for or the site nearest the collector channels.
Okay. In addition of a drug like mannitol, is addition of a drug like mannitol required pre-op if a patient has high IOP at the time of surgery? Well, I don't think that you would like to put your patient on mannitol prior to surgery. For one, before the surgery and upon entering your anterior chamber, your pressure will definitely go down. And I will not like a patient who will be more toxic looking because of the side effects of mannitol. So I will not require addition of mannitol for patients who will have this type of surgery, and I don't think that it will help.
There's a question here that says, how can you do MIGS in a closed angle? Does MIGS require visualization of the angle? Yes, absolutely. Angle surgery requires visualization of the angle, but theoretically, perhaps maybe if you're doing a combined phaco-sen or perhaps maybe a phaco iStent, the minute you remove the cataract, you can easily perform gonius suniculitis or GSL, open up the angle a bit so you can see the trabecular meshwork and insert the MIGS device in that area. I have heard of people in Singapore who have performed who have implanted a SEN 45 gel implant in patients with mild angle closure. However, that forces you to aim and essentially insert the SEN implant closer to the endothelium, and that might be a bit risky. But yes, certainly it can be done.
Your experience with close angle glaucoma, Rainier, with using SEN?
In the other patients that I had, I have a PAX patient who I did phaco on and put a Zen in afterwards. Of course, the removal of the lens made it easier for me to put in the Zen after. But regardless, it's still a little bit tricky because you don't want the tip of the Zen to maybe rough on either the iris or on the endothelium of the cornea. So it's not ideal, but it's doable. Um, Maybe not on the first few cases that you might have, but once you get the hang of it, and because when you do the Zen, they offer or provide you a go on your lens so that you can visualize the angle. So when you're a little bit more in tune with visualizing the angle from the reverse view, then it might become a little easier for you to perform these procedures.
And the special consideration angle recession patients. Well, I don't think that there is a special consideration for angle recession patients. Well, your angles to start with are very good. It's deep already. So you can just aim for your a little above the or the trabecular mesowork area and put this. I'm talking about the SEN or the in focus with regards to angle recession patients. Okay, so I don't see any. Um, eh, do you think, Romel, iStent will work on this kind of patient?
Yeah, if an eye stent is placed well, it will certainly lower pressure. But typically in patients with angle recession and IOPs are high, and your target IOPs are fairly low, I would personally put a blood forming MIGS device rather than gamble on on a Schlems canal type of MIGS, such as the iStent, since the pressure drop is not as impressive as that of a blood forming MIGS.
Perhaps maybe amongst the available MIGS that you have in the country, Zen would be ideal for a patient with angle recession, specifically because your angle is wide open, and because your drainage angle is already compromised, your Schlems canal might not be working that well. If you put in other types of MIGS, it might not actually drain through your trabecular meshwork. So getting a Zen from the anterior chamber to the subconjunctival space might actually be the best. And the only problem I foresee would be during the surgery, the patient will have very high eye pressure. So you might have to bring that down a bit just so that you have a better view, and the patient might not, because of the decompression immediately after you put in the Zen, if your patient is cupped out or has severe glaucoma, your fear of wiping out whatever vision is remaining might just happen. So you just have to make sure that the pressure does not go down immediately too low in the 4 to 8 range, 4 to 6 range, because the Zen can actually do that. So if your pressure is in the 50s or 60s and it drops to very low pressures, the fear of wipeout might just happen. So just be careful with that.
All right, an interesting question just popped up. Anyone using this in pediatric glaucoma? So I think with pediatric glaucoma, I would go for the goniotomy assisted DGAT. No, so it's an ab internal goniotomy tube that you put in through the SLAMS canal, and then do a 360 degrees trabeculectomy. So I think that's the most promising MIGS procedure for pediatric glaucoma. Any incidents of hypotony with MIGS? Yeah, there are.
Hypotony with MIGS is a particular feature of bleb forming MIGS devices such as the SEN. In fact, you sort of like expect hypotony in the first day or two. You know, it's not uncommon for you to have pressures of 2 or 3, but that quickly rises as the gel stent, the SEN implant actually expands, you know, because as it becomes wet with aqueous, it starts to expand. And it's also important to note that when you implant a SEN gel implant, you're actually using a gauge 27 needle, inside the lumen of which is actually the actual SEN implant itself. So as you implant the SEN, you're actually creating a bigger tract than that of the actual device itself. So yes, you do experience hypotony in bleb forming MIGS. For the iStent and the hydrus, which essentially relies on or works by connecting the anterior chamber to Schlemm's canal, you do not expect hypotony with these devices because the drainage is physiologic, and the lowest pressure you can actually get will depend on your episcleral venous pressure. So that in itself is a stopgap measure for hypotony.